Hi, I'm Tanya Dorf, a medical oncologist from City of Hope in California.
And I'm Chuck Ryan, a medical oncologist from Memorial Sloan Kettering Cancer Center in New York.
And we're going to talk a little bit about PARP inhibitors in the metastatic hormone-sensitive prostate cancer setting, specifically the AMPLITUDE trial, which reported earlier this year.
So it's always interesting to see what happens when you take an existing therapy and you move it into an earlier disease state. And that's exactly what was done with AMPLITUDE. This was a randomized phase 3 trial looking at patients with HRRM mutations, inclusive, of course, of BRCA2, BRCA1. And most of the patients in the trial were BRCA2 patients, let's put it that way. And they were all metastatic hormone-sensitive prostate cancer.
Yeah, and so it was, of course, combined. It was ADT abiraterone niraparib or ADT abiraterone placebo. And patients were allowed to receive docetaxel before going into that randomization because many of these patients actually were high volume and synchronous, sort of, more aggressive types of prostate cancer presentations.
That's right. And the results are, I would say, fairly unambiguous, right? You have in the BRCA2 population, we had a really impressive hazard ratio in the rPFS primary endpoint, which was 0.52. So I always say that as the use of a PARP inhibitor with upfront therapy reduces the risk of progression by 50%, which I think is a more digestible sort of way to look at the data. And the survival are also encouraging, but not yet final.
Yeah, I agree. And when we look at the overall population, which included other alterations in HRR genes, it was also positive for the rPFS endpoint, although the hazard ratio was not as strong. And, some people think that it's largely driven by the BRCA2 population.
Right.
But we do get some subsets. We get to see how the different genes perform in this study. I really like the FDA pooled analysis when it comes to some of the more rare alterations to try to give myself a sense of how to counsel a patient, how much effect to expect potentially, which is definitely different among some of the different genes.
And we should also make sure that we reiterate that alongside these data using a PARP inhibitor are data that are emerging showing fairly consistently that patients with BRCA2 alterations and HRRM alterations have a poorer prognosis than average. So it is a prognostic risk to have one of these alterations, so it's a good thing to have the therapy available.
Yeah, so the AMPLITUDE study, I think, will change practice. Obviously, we have to wait for regulatory approval. And I don't know how you feel, but to me, BRCA2 is just such a compelling story for biomarker matched to therapeutic that I would prioritize this even in the setting where we may have multiple approvals for triplet therapies in MHSPC.
Absolutely. I think this one doesn't really need to be sort of put into the context of, high versus low volume and lutetium and capivasertib, and those are all important conversations, but this is sort of a class in and of itself, don't you think? The BRCA2 population where we now have a series of very well-designed and well-conducted clinical trials demonstrating the efficacy of PARP inhibitors in this setting. I guess one of the other key points here is that it reinforces our need to do genomic testing early on in the clinical course. If you are waiting for CRPC to do next generation sequencing, you're going to miss this opportunity for a 50% reduction in the risk of progression and something like a 30% reduction in the risk of death.
Absolutely. So increasing our utilization of both germline and somatic testing right at diagnosis for advanced prostate cancer is imperative. I think the other point, maybe just to touch on, is management of toxicity.
Right.
Because these patients, may not be expecting the additional side effect profile. They might know a bit more about hormone therapy and what to expect there. But so we know that, as many as a third might end up having grade 3-4 anemia and need a transfusion. So kind of preparing patients ahead of time, watching them more closely than we watch our doublet patients. So we might feel comfortable seeing every 3 months. We have to see these patients a bit more frequently in order to detect and manage the toxicities.
Yeah, I think that's right. I think that it's not anything we're not capable of doing. It doesn't create some new major challenge. It's just sort of close follow-up is the key. There was a case of MDS, I think one case that occurred in the niraparib arm, which is something that we've been a little concerned about. Is there an effect on the bone marrow long term? We, of course, will expect further updates on this trial as time goes on. We'll want to watch that hematologic toxicity should it be something that becomes more common. But by and large, actually, I think maybe we were pleasantly surprised at the lack of MDS. One case out of several hundred patients. A concern, but not a major one, I think.
Yeah, I think in the CRPC setting, we have to remember our patients at that point may have been exposed to a lot of radiation, maybe chemotherapy and other things that might make the marrow different in terms of how it reacts. So we do, on the other hand, treat these patients for longer. So those CRPC studies with PARP inhibitors, the patients were not on the drug near as long.
Right.
And so I do think we want to stay tuned for the longer term follow-up, just to make sure we don't see that emerge as a more significant risk.
And so this is all subject to regulatory approval, but I think encouraging another step in both the development of PARP inhibitors, another step in the development of precision medicine for prostate cancer, and another step in a positive one for patients with metastatic hormone-sensitive disease.
Absolutely.